So the title of the symposium now is Advanced Colonoscopy Techniques, but in fact this is really basic stuff. This is things what you're going to hear now. The next hour is really something that everybody should know, and everybody should know this because you should be able to do colonoscopy in patients who are not under anesthesia and try to do painless colonoscopy. Me personally, I like very much to do colonoscopy without anesthesia. I think it's sportive, and I like to talk to the patient at the same moment, and at the same moment try not to create pain in this patient. So the first lecture will be given by Roland Valery on conscious competence, the art of knowing why you do what you do and why it works. Ronald.
My name is Roland Valery. I'm going to be discussing the concept of conscious competence and how we apply it in endoscopy. So the first question is, what is conscious competence? Well, conscious competence is knowing what you're doing that makes you competent so that you're able to explain to someone else how to achieve competence. It's probably easier if I show you some examples of application of conscious competence. And the tip of the scope is just looking into the descending colon. This is the descending sigmoid junction. Now, I was doing some training in Sweden, and a highly competent endoscopist, done thousands of colonoscopies, was doing the procedure, and he had a loop exactly like this. This wasn't actually the case, but it was exactly like this. And when he pulled the scope back, it fell out. And when he pushed it in, this patient, who was a young woman, was in tremendous pain. And I stopped him and asked him what he was going to do. And he said, well, he didn't see any alternative but to advance the scope. And the patient would just have to put up with the pain. And he was very keen for other suggestions. And I explained to him that what he needed to do was to get this spiral loop in as far as possible in one plane. And unless he had it in one plane, at the moment it's in two planes, then he wouldn't be able to pull the scope without it falling out. So with some help, he got the scope in almost in one plane here. You can see that it's a much straighter end loop. This is a lateral view, just to orientate you. This is posterior, this is anterior. This is the AP view, this is left, this is right. What happens when you get the scope in this position is there's a tendency for it to fall one side and the other. And unless you correct for this, and it can go one way or the other, and it can go one way then the other, if you don't correct, then the scope will fall out. And so I explained this to him, and he can feel when it needs to move. And he very gradually pulled the scope out to this position. Now, this is usually what the colon looks like, or the shape of the scope at this point. And this is a highly unstable situation. I was able to tell him that he must be very careful here, very small movements back and forth to allow the colon to pleat on the scope. And he needs to slowly tip deflect upwards to straighten the scope, and then very slowly drive up into the descending colon. And if you do anything quickly at this point, the scope just falls out. Now, he managed to resolve this loop and get up to the splenic flexure in one go with that instruction and explanation. How can you improve your conscious competence? Well, top of the list, I'd say, is scope with another person. And as you're doing the scoping, discuss with that person what you're doing. Share ideas of solutions, and particularly share ways of explaining solutions, because sometimes it's very difficult to do that. And when you complete a maneuver, reflect on what you did to complete it. Maybe just chat to the support staff, the nursing staff, tell them what you're doing and why you're doing it, and why you need compression, where you need the compression. Think about the anatomy of the colon and how it affects what you're doing. Think about how position change affects distension, fluid, and angles. Use an imager if you have one. We have often found the imager in the cupboard. And when we go to places, use competency frameworks such as the DOPIS, which is the polypectomy competency framework, I used this competency framework to enhance my conscious competence of polypectomy. I found my polypectomy was much better. I was much more confident, much less anxious, much more effective, and I found I could teach polypectomy much better by using the competency framework. And finally, I would encourage you to watch Consciously Competent Endosophagus.
Okay, thank you very much, John, for this, Ronald, for this really very interesting talk. Sometimes a little bit philosophical, I think. I was wondering, so because we are trainers, but in fact we haven't been trained this way in the past, and I'm sure that you haven't been trained this way neither. So I remember that at a given moment I was reading an article on doing colonoscopy. I think it was from Peter Cotton. There's a book from him. And then suddenly I saw the light. I think I saw the light about so how the scope moves in the... So but that's of course a problem, I think, that well, we ourselves are not formed this way. So how did you get this, you and John, and so how did you learn to do this way?
Well, so I was trained by two quite famous colonoscopists, one called Richard Hunt and the other Christopher Williams, who sort of has put colonoscopy on the map. But really, you know, when I reflect back to those days, sort of what we know now compared to what we knew then is just in a different world. We were using the fiber optic scopes at that time with extension arms. It was a completely different world. So I think the answer is we weren't taught, really. We were just given a go, and somebody would take over, and you'd ask them what the problem was, and they couldn't articulate what they'd done. It was extremely frustrating. And even when we started training in 1999, with courses, I don't think we really knew what was going on. Yeah. But and it wasn't really until the next decade, you know, when we were doing all these courses together that we suddenly got to grips with this, and we realized how important this was.
Okay, thank you very much, John. Now that you're on the screen, we are going to proceed with your presentation. I just changed a little bit the order because we were talking about loops, etc. And so your lecture is about the commonest loops at colonoscopy, how to prevent them, and how to remove them if they occur.
I'll unmute myself. This is going to be interesting because they're removing my slides. So we just moved the slides on. I haven't got any speaker disclosures. So just next slide and the next slide. So just a little bit about terminology first so you can understand what I'm going to do. I'm going to show you two video clips which are very different. One is me trying to explain loop resolution to a trainee, and the second clip is more of an animation talking about different types of loops and how they form. So just about the terminology. A simple loop, I think, is a simple loop. A complex loop is a bit more difficult to maybe define, but it's multiple loops, or I would say multiple steps to resolve the loop. So some loops come out with basically a pullback and a little bit of torque, and others are much more complex than that. And I think the complexity is driven by the speed at which you have to do certain maneuvers or multiple things together, combined with exquisite tip control. And I think that's what differentiates a complicated loop or a complex loop from a simple one. I will talk about stable loops and unstable loops. If you start with an unstable loop, because everyone does, as you push in, you lose the one-to-one and a loop forms. And once it's reached its fullest extent, you go back to one-to-one and it's become stable again. Loops can obviously be resolved and some can be prevented, and we'll give you some ideas of how you might do that. And I would say if you partially resolve a loop, inevitably it will reform. And if it's reform and you push through, you're going to cause some pain. Next slide, please. Next, click. And some related terminology. I talk about true and false one-to-one. Well, true to one-to-one is when you've got a completely straight scope, and a false one-to-one is where you think you've got a completely straight scope, but you've got a big loop in it, but it seems to be moving one-to-one. And I use the phrase buckle, which is a slight deviation from having a straight scope, and it's the precursor before you actually get a loop forming. And I think you need to understand loops can form in 2 and 3 dimensions. Next slide. So On a really simplistic level, you can push the scope in, it'll go forward until it meets resistance. Next. And when it meets resistance, it starts to buckle. And then you start deviating the tip to try and find the lumen. Next. And if this happens, next, the scope will move up, but you're not moving forward as you're pushing in. Next. And what you'll find is that you'll feel resistance in your right hand. You can choose to ignore it and keep pushing, but actually the resistance tells you you're forming a loop. And often before that happens, if you look out the corner of your eye, the toes of the patient begin to curl. And that's an early indication they're feeling discomfort. Next. If you keep pushing in, it will just form. Next. So the simplest loop is an end loop, and it's in 2 dimensions. And Roland articulated before, when you have a complex loop, one of the ways of solving that loop is to get it back into 2 dimensions and have a simple end loop. And the resolution of a simple end loop is simply to pull the scope back. It's a little bit complicated than that, but it's, in essence, that's what it is. Next. And a complicated loop forms because if you keep pushing in, the mesentery elongates, and as it does, it becomes unstable in a 2-dimensional axis and begins to flip. Next. And as you push in, this component of the loop will rotate one direction or another. Next. And you form one of these, which will either be a alpha loop or reverse alpha loop, depending on which way it rotates. Next. Okay, and next. So loop formation principles are the longer the mesenteric or ligament attachment, the more variation in looping is possible in that segment of the bowel. If the attachment is short, usually it's only possible to form an end loop or an end spiral loop, and the short attachments tend to be associated with significant discomfort. And different parts of the bowel are more susceptible to looping, and that's why the commonest loops occur in the sigmoid colon, and I would suggest followed by the splenic flexure and the transverse colon. Now I'm going to show you a short video clip I did with one of my fellows, so just bear with me if you could run the video. On a really simplistic level, that's the simplest loop you could possibly get, isn't it? Mm-hmm. It's a 2-dimensional plane, and to remove that loop, you do what?
Just pull back.
Pull back, and it disappears. And it forms again, and it disappears. So what changes when you take the loop out? What do you have to do differently to stop the loop from reforming? What causes this to form in the first place, do you think?
So if you've got a bit of the bowel that's quite floppy, then it will just move in the abdominal cavity. Mm-hmm.
That's not why it forms though, is it? What's the difference between this and this? What did I just do?
So you put some pressure on the tip here.
Did I put on?
Not very much. Just.
Yeah. Do you want to just not touch it? And as I go past, just add a very light weight.
Yeah.
So that tells you that the least bit resistance at the tip will tend to buckle the instrument. Mm-hmm. Okay. So one of the key things is we're going to try and avoid hitting the bowel wall because we know that adds resistance and that is more likely to form a loop. Yeah. Now, in resolving loops, you only have to do 2 things. So one of them is pull back. What's the other thing?
Torque.
Torque. And torque becomes relevant when we move from a 2-dimensional plane to a 3-dimensional plane. And as you rightly said, the bowel is floppy in the abdomen, and therefore it will regularly form not just a simple loop, but complex loops. Mm-hmm. And actually the loop can even resolve completely on itself, can't it? So we need to pull back and we need to add some torque. And the question for loop resolution is a really simple one. And if you push in and there's a little kink, you can add a little bit of clockwise torque and it goes up. And that's a much more common loop that the trainees will struggle with. It's such a good session, people ringing in wanting to come into the room is what's happening there. So, pretty good. And the final thing is when it's a really tight end loop like this, if you pull back, you go back. If you push in, the loop gets worse. If you had one of those, what do you think the solution to that one would be?
Is it to try and deangulate the tip itself?
So I'm looking into the lumen. If I push in, the loop forms. If I pull back, the scope comes back. It's an tight end spiral. How are you going to resolve that? What you're trying to do with the scope? Go back to the first lesson.
So you want to straighten it?
You want to straighten the scope. There's only 2 ways to straighten the scope.
Pull back or torque.
Right, or do them both together.
Okay.
Do them both together.
Yeah.
So the torque action will straighten the instrument and drive the tip forward at the same time as you pull back. So therefore you're doing the same thing, the tip's not moving. So you're pulling back and rotating at the same time, the tip's not moving. It's the same distance, the same distance, the same distance until you reach this point. Guess what you do?
Insert.
You can push forward. So often what actually happens is, as you rotate and pull back, the tip naturally goes forward anyway. It naturally goes forward. So the key thing to do that is you often have to do 2 things at once, but the movements are incredibly small. So if I hold the scope like that, you hold it with your right hand, you're going to have to torque it which direction?
Anti-clockwise.
Look at how much torque you have to put on. Very little for a big movement. So you want to start pulling back and rotating, pulling back and rotating. You've moved it through what, 30 degrees, if that. 30 degrees, if that, and you've moved the scope back maybe a centimetre, right? So I can't have big movements. I need very, very precise movements, and I need control of the tip. Okay, so tell me some basic principles about loops and resolving them.
So the best way to move forward is to have a straight scope, luminal view.